right. And for our next speakers, and for anyone who's just joining us online or here, I'm Dacre Knight. I'm the director of the UVA EDS Center, joined by Ina Stevens, my associate director. So glad you all are here. For this next session, we have a dual superstar lineup. We're going to welcome Jodie Stellern and Dr. Carley Whitt. Jodie Stellern is a physical therapist with specialized training in orthopedics, sports medicine, and rehabilitation, including techniques such as trigger point, dry needling. Her work focuses on helping patients improve function and manage chronic conditions. We are ever so lucky that she is based in Charlottesville, Virginia, and has vast experience in EDS care. So very lucky to have her. Dr. Whitt is a physician in physical medicine and rehabilitation at University of Virginia. And she's focused on restoring function and improving quality of life for patients with complex chronic conditions like Ehlers-Danlos Syndrome. Together, they bring complementary clinical perspectives to this session. So please join me in welcoming Jodie Stellern and Dr. Whitt.
Hi, just making sure my mic works. Normally, I don't need one. I'm pretty loud, so. But yeah, thank you for having us. Jodie and I are so excited. We're going to be talking about treatments of musculoskeletal pain today. So our objectives are going to be to try to talk about what causes pain and how we can work on treating that. Some disclosures, we have none. We brought a bunch of toys here that we use in our experience and just our own lived experience with patients and ourselves. So no connection to them, just things we find helpful. So to start, what causes pain and hypermobility? I think we've talked about this a lot over the past 2 days, but to kind of parse it out a little bit more, there are structural factors, being the joint and the instability and the microtrauma from repeated subluxation from the fact that the joints are loose. There's the myofascial components, meaning the tension that can happen from overuse, the trigger points that Jodie's so artfully targeting in her therapies. And then, of course, we can never forget about the psychosocial impact of both having a chronic condition and just existing in the world that we do today. And all of this plays a role in how our body perceives and processes pain. So pain's coming in through our spinal cord, the signals are being sent up to the brain, and we are getting our perception of pain. I was thinking about a way to explain this process of central sensitization, and what came to my mind was when I drive in my car. I don't know about any of you, but when I get on the road, I'm just doing my best. And my car is equipped with cameras, and they're also doing their best. And those cameras have gotten accustomed to the fact that I sometimes get kind of close to other things. So those cameras beep a lot. And that's like my nervous system saying, hey, there's a threat, there's a threat, there's a threat, slow down. But my car is so used to the fact that there are these constant threats on the road that it also reacts to leaves and things that I don't plan on hitting. And so that's kind of how I think about central sensitization. Your body is so used to pain that the signals are being amplified and that perception of pain can be heightened. This does not mean in any way that your pain isn't real. It just means that your body is amplifying the pain signals that are coming in. The other aspect of this, which I'm just going to touch on since we've talked about it so much in the last 2 days, the dysautonomia. So the nervous system, we have nerves in our periphery that are sensing things. And then we have nerves in our heart and in our more central system that are regulating our heart rate, our blood pressure, our temperature. And so many components of EDS and HSD, as we've talked about over the last 2 days, are going to contribute to this dysregulation of the nervous system. Joint instability is going to stretch nerves. Things like POTS, we're seeing small nerve irritation that's leading to dysregulation, as well as many other mechanisms we've talked about. And then, of course, mast cells, which it sounds like I have vastly oversimplified on this slide, but there is much more to come from all of you guys' exciting research. But all of this is coming together to create those symptoms of dysautonomia that many of us experience, including the dizziness when standing, fast heart rate, fatigue, nausea, brain fog. And that's all coming together in that experience of pain in hypermobility. This is another slide I wanted to share because it's actually from a surgeon that I saw out in Seattle. I thought of him yesterday when we were talking about orthopedic surgeons that get it. This is one that gets it. He actually drew this himself. I won't go through the whole thing today, but essentially it's just saying that lived experience that you all are dealing with right now, that nothing is happening in your body in isolation. It's all coming together to contribute to your experience, whether it's your posture, it's your stress, it's gravity, it's the weight of, breast tissue, stress on nerves from overexertion and overstretching. It's all coming together to make up your experience. And so why does any of this matter? Why does it matter what's causing our pain? Well, the reason it matters is because that's how we target treatments. When I was asked to speak, the first thing that Dr. Knight and Dr. Stevens wanted to hear about was everyone asks about prolotherapy and PRP, which I'm going to talk about as well. But I think injections are just a small part of the management of pain in chronic conditions like hypermobility and Ehlers-Danlos. And so the things that I do personally, as well as recommend for my patients, is getting back to the basics. We need sleep, we need nutrition, and we need to be able to regulate. And I'm not going to steal Jodie's thunder too much because she does a great job talking about pacing. But these are just some resources here. By no means do I mean by saying that these things are simple that they're easy. They're not easy. But they are the building blocks to managing our chronic conditions. Now I'm going to try to convince you that stress has a mechanism for causing an increased pain, not just because we know it does because we experience it, but because there's science to back it up. So whenever you have anxiety and depression, that can increase pain. But when you have pain, that increases anxiety and depression. But there's also hormonal mechanisms for that, which I love that I came right after the talk that was just given, really backs that up well. But there's also, going to be inflammatory cytokines. And like we talked about, that central sensitization, me driving my car around, getting scared by leaves when really it should be prepared for cars. Oh, sure thing. I've never gotten that request before. Yeah, please tell me if I'm not loud enough. I love to hear that. This is just a little bit more getting into the anatomy and physiology of what causes pain and how stress plays a role in that. Some of this I'm going through quickly because I wanted you to have resources for later. But getting back to treatment, structured rehab and structured physical therapy has been proven to show a decrease in pain scores and to help with pain and lifestyle management in chronic conditions. And so the main bulk of this talk is going to be how can we get people moving safely? How can we get people doing the things that they love? And one of those ways is just having a very strong relationship with physical therapy. This is just some resources for later. One is Psychology Today. I try to give it to any patient that will take it. This is not to say that your pain is in your head in any way. It is to say that there are multiple things going on. You have pain, and that causes stress, depression, anxiety, PTSD from providers that don't understand, trauma, all sorts of things. So having someone that's experienced in pain psychology, someone who can help you work through some of these things, I think is really beneficial. I like this website because it will make sure you can filter by like your insurance and location and gender and all sorts of other things, what type of therapist you want. And so I think it's a really great resource to have. Another thing that I have here is just a breathing exercise. I think that one thing that's super important that we're going to get into more and more is core stabilization and how to get moving without everything hurting. And that starts with small motion and stability. And the root of that is going to be breathing. And then the question becomes, which I think we've all had this question at some point or another, what about when all of that conservative stuff just isn't enough? And we absolutely have patients come into our office every day. They're in persistent pain despite therapy. They've, tried all these things, been to all these places, in some cases flown all around the country, and they still just can't get back up on their feet. They still aren't able to do the things that make them a person and make them enjoy life. And so that's when we start to think about things like injections. And I alluded to this at the beginning, but I really, truly believe that injections are only a small part, even though it's a big part of my training and hopefully a big part of my practice in the future. Injections are going to be things that target focal issues. If I had an injection that fixed widespread pain, I would be a billionaire and probably not in residency. But until we come up with that, we do have ways to target specific issues. And so potential ways to target things, trigger point injections, starting out with just dry needling like Jodie does. I'm actually getting my training in it too. I'm on to the next level in July if they'll give me a little bit more time off. But you can also do trigger point injections instead of just the dry needle without medication. You can add things like steroid. We can add anti-inflammatories. And then, of course, the thing that I get the most questions about is prolotherapy and PRP, as well as Botox for focal muscle overactivity and dystonia. So to compare prolotherapy and PRP, so prolotherapy is going to be essentially a dextrose solution, an irritating solution that you put into a ligament, into a tendon, or into a joint with mild arthritis. And it's going to cause an inflammatory reaction that lays down new connective tissue. So this is not magic. It's not going to grow you a new tendon, but it can help repair damaged tendon and ligaments. It can help strengthen things that are lax. And as we know, laxity is a big thing in hypermobility and Ehlers-Danlos. So it definitely can help, but it's not something we typically can do over your entire body. So, you know, if you have a couple joints that are the most bothersome, you have an ankle that keeps subluxing, you have repeated dislocations, the prolotherapy is something that has been shown to really help. There's no blood draw. It's not covered by insurance, or at least any insurance I've seen. And the amount of injections you need is variable. I get prolotherapy in my spine to help with instability and cervicogenic headaches, and I do it about every 6 months. Sometimes I go longer when I don't have time. Some patients will come for a couple injections back to back every 3 months until they get benefit for a year. It's very variable. We always hope for better and prepare for worse. PRP, on the other hand, is going to require blood draw because it's taking your blood, we're spinning it down, pulling out the platelets, which is the part of your blood that has those really great rich growth factors that stimulate tissue repair. Again, we can't regrow something, not yet, but we can help where there's been tendon injury and ligament injury, help to promote a healing response. There's also increasing evidence that doing a little bit of tendinotomy, where we're going in and like poking the tendon multiple times and essentially putting small holes in it, can generate regrowth as well. Which I know sounds really scary. We're not trying to actually break the tendon, and you're not making holes that are big enough to like hurt its integrity. But again, it's something that's not covered by insurance. It's going to require blood draw. And often with this, depending on what type of setup the doctor you're seeing in clinic has, certain setups can pull more platelets out at a time. So the amount of blood they have to take and the amount of injections you have to get that robust benefit is a little bit variable by provider, because right now these things are not standardized. There is some evidence, you know, we're doing research and there is evidence to support them, but there's not the robust evidence that we see in other fields for, you know, treatment of stroke, for example, a very robustly researched field. But that's one of the things that is so essential in the hypermobility field and why we're all here today, is that there needs to be more research. And could these things be expanded, and how can we make them even better? And then finally, you know, kind of the heart of this talk and why Jodie and I are up here together is that multidisciplinary care is I would say PT is number one, the thing you need, but number two is a good team. And so I maybe didn't even explain what PM&R is, which might be helpful here at the end. So it's physical medicine and rehabilitation. I realized talking to some people that a lot of you haven't ever heard of that, which is funny because I didn't actually know I was seeing a PM&R doctor until one day I was like, what are you? That seems kind of cool. I'm in med school, maybe I'll do that. But it's an entire specialty around function and trying to get you back to what makes you you, trying to get you, help you meet your goals, help you do what you need to do to function and live. So for some people that might be getting out of bed. For some people that might be running a marathon. We meet you where you're at and try to really see you for a whole person and get you to meet those goals that are most important to you, whatever they are. We work very closely with physical therapy, occupational therapy, pain management, and when available, psychology. If there's any budding psychologists in the room, we need you. And so by having this strong multidisciplinary team, and conferences like these are so essential to building that, and to things like Dr. Norris's lab. I loved the patient scientists. I think that is so exciting because we need more providers that care and that know about these conditions and how to treat patients empathetically. And so I'll go ahead and pass off to Jodie, but we're going to talk about all these different things we brought at the end as well.
Can you hear me? Okay. Can everybody hear me? Okay. All right. Well, thank you, Carly. So my name is Jodie Stellern. I'm a physical therapist. I've been a PT for the last 25 years, which is hard to believe, but here we are. And for the last 4 or 5 years, I have been exclusively or almost exclusively treating EDS and its comorbidities. And then I have sort of morphed into some long COVID as well because of the phenotype. So for my portion of the talk today, I just really kind of want to talk in generalities about PT because I don't like to give out specific exercises because we are all very unique and individual, and it is not a cookie cutter approach. That is the main thing that I will say. What works for some does not work for all. Let's see. Let me go back to, there we go. So what we're really wanting to do, first of all, you want to find a knowledgeable physical therapist in EDS. Well, that sounds really easy to do. No. So let me just ask this question. How many people in this room have had a bad experience in physical therapy? Yeah. And so I am going to live and die on the hill that PT does not need to be painful. It should not be painful. And that if it is, then it's my job as the therapist or your therapist's job to figure out, all right, how we're going to do it differently, because it doesn't have to be painful. A little bit of discomfort is okay. Muscle burn, some fatigue that doesn't cause an energy crash, all okay. Pain, not. You also want to have someone who's going to speak about or look at you as the individual that you are. Really try to get to there. No, there we go. Sorry, these look a little bit different from we put our slides together, so they look a little different. Thank you. Perfect. Thank you. Yay, there it is. Okay, I'm familiar with that. All right, so yes, you want to look at somebody or find someone who's going to look at you as the person that you are, the whole person, and not just the body part. I've also had a lot of people come and tell me, well, my last physical therapist told me I could pick one body part. What? That doesn't work. We have a lot of body parts that we need to work on. So really important. And the other thing that Shilpa also kind of touched on is that you want to find someone who can work with you in a trauma-informed approach. So what that means for me in the PT clinic is where are you going to be best suited in my clinic? Do you need to come into a large space if you've had a lot of trauma and don't do well? Are we opposite genders that may not do well in a closed space as well? Asking the patient before you ever touch and say, this is what I'm going to do, and etc. So really trying to shut down some of the autonomic nervous system effects that we can see from the medical trauma and gaslighting that many of us had or have. So when I get to evaluate a patient, I've got about 45 minutes, which by today's standards is actually pretty good. And I want to know everything. I want to know from birth up until present day. Did you meet your markers? What was your childhood like? Where was it spent? What kind of pets did you have from an environmental perspective? And why does that relate to me as PT? Well, again, I need to treat you as the whole person that you are and think about any of the possible comorbidities that we could have. And so learning about any traumas, and as you were again pointing out, I ask every single one of my patients, I don't need to know any details, but are there past traumas that I should be aware of, because I need to be sensitive to that. And that also helps me figure out what's going to happen with your nervous system. So posture. We've all heard about posture, posture, posture. It is so important for us, because my example is, if I stand like I really want to, I'm going to be here. And that puts a lot of stress on my hypermobile neck, and my vision is already going a little wonky here. And versus where I would want to be, and I would invite you to all stand up if you want to and try it. But we want to get forward, backward weight distribution of your feet, side to side as well. So kind of equal distant down through your arch. And then, come on. Unlock your knees. Don't bend your knees, but unlock ever so slightly. And then, so I like to start from the bottom up with posture. I think that's much easier. So again, we've got feet. I've unlocked my knees, and then my pelvis. If it's a bucket, don't let the water tip forward. Don't let it tip back. And if I do that, that engages my core. I don't have to do anything from here up for head and neck. Chin tucks. We've all seen chin tucks. That, in my opinion, you can sit down if you'd like. You want to stand up, please do. In my opinion, chin tucks are one of the worst exercises that a hypermobile group of folks could possibly do. And so if we can get you from here up, that will be a lot easier. And then ergonomics, our core goes into that, as Carly said, as well, for stability. But ergonomics, any kind of external supports. These are pillows that I have taken these on airplanes, and they are fantastic. So anything that we can do to build the world up around you, rather than you kind of caving down to the world. And that kind of ties into the joint protection piece of things. You want to avoid the end range of motion. So just because I can reach all the way into the back seat of the car without taking my seatbelt off does not mean that I should do that. It's kind of fun though. So sleeping. This is probably one of the more frequent questions that I get. We'll start at the bottom here. So here, you want to make sure, if you can, for side lying, that you have a pillow that is supporting ankle and feet, because we've all heard about putting a pillow between your knees. But if you don't get it between your ankles, then your ankles just kind of flopping in the wind, and that does not feel good for an extended period of time. Getting the pillow between your knees here, you want the height of the pillow so that it is going to kind of level out your hips, so that you're not getting cross and you're not too far into abduction. So ideally, I would have had a body pillow here, just to give me a little bit more support coming up here. But then if we move up to the top shoulder, if I had a body pillow, that would give me a little bit more support under here. And again, you want to put something. So Squishmallows work great. My daughter turns 13 tomorrow, so I'm stealing her Squishmallows that she is getting rid of. Put it under here so that we're going to keep your shoulder in the most loose position that it can be in, like so. And then by having a little bit more support underneath me here, it's going to build up so I can't collapse down into the bed and put more pressure here and on the shoulder. And then the thing that I think is really challenging is the bottom shoulder. What do we do with that bottom shoulder? Because it feels real good to reach out like that, or it's really easy to do, I should say, but when you're really distracting the joint and making it more unstable. So if you can stack yourself like you are if you're standing here, and then we build the world around you with pillows. Again, we build the world around you, you don't go down to the world. So put an extra pillow underneath here for your shoulder. And then head and neck. I also get asked all the time about pillows. I think it's so individual, and I don't have a great answer for that. But what I do know is that if you're using a pillow, get it all the way down into your shoulder to keep your head in a neutral position this way. And then you can kind of tuck it ever so slightly. You do it that side. Ever so slightly here, so that you're not going to go into rotation of your neck. And then if you're going to be on your back, something underneath your knees and maybe your ankles, depending on how that feels. And then the important thing here, getting something underneath elbows, forearms, hands. And then if you need to, you can even move these pillows back up underneath your shoulder just a little bit to give you some support there. So exercise progressions, again, we'll kind of talk general strategies. You want to start proximal, meaning in the trunk, and work distal. And why? Why do we want to do that? Well, many of us do not have great proprioception or where the body is in space sense. So my analogy is randomly, I was a power lifter in college, don't know. I could bench press 250 pounds, but for me to stand on one leg and then throw a ball back and forth, forget it. So we want to start proximal, making sure that we know what someone's core is doing, and then we can work out to the extremities. And to know what the core is doing, there are several different things that we can try. There's a biofeedback unit that gives us some kind of external feedback what your core is doing. You can use mirrors, any kind of, again, external feedback can be really important. And that sort of goes back to neuroplasticity and how our brain can learn and adapt. And so if we use multiple sources of motor learning, such as repetition, and then one with an external source like a mirror, that uses multiple parts of our brain. And so that can be really helpful. To stretch or not to stretch, also one of the major questions that I get. I can't give you any kind of study quote, but I will give you my opinion. I feel like if you want to stretch your hamstring, for example, if you do that stretch and you feel it in the hamstring and or the desired muscle group, but you do not feel it in the joint, I think that's okay. If you feel that stretch anywhere in the joint, I would advise backing off, because then you're really not stretching the muscle, you're stretching the joint, which we don't need to do. We don't need any more kind of micro traumas. And so I'm going to give stability another plug, and I would prioritize things that really do promote stability. Pilates can be great if we know what your core is doing and it's doing what we actually think that it should. It's a really good form of stability. There are multiple different hand holds and foot holds that can be used. And then yoga. I am not at all qualified to discuss the multiple types of yoga, but what I would say is the same kind of generality, that we don't want to go to end range when you do it. It should be more for stabilization, proprioception, where your body is in space, and then maintaining that for stability. So aquatics. Some people will ask about aquatics. That's the other thing that I would really, a lot of people do well in the water. However, you have to think about the temperature of the water. There are therapy pools that are about 95 degrees. If you have POTS or dysautonomia symptoms, you need to be pretty careful getting in and out of a warm pool. And if you have notable POTS as well, sometimes the pressure of getting in and out of the water can be really problematic and provoke symptoms. So if you're a provider, you just need to be really careful in terms of why you are doing the things that you're doing and why you're making these clinical decisions. And so, yes, no open wounds in pools. So management-wise, in PT, things that we can try, microcurrent. We're finding out more about microcurrent and its longer-lasting effects for pain. Dry needling, cupping, fascial release, craniosacral therapies, taping, as we all know, supports versus maybe immobilizing. There are some really great supports out there that have medical grade compression versus immobilization, so that you're not going to get weaker when you are in the support. Mobility aids, any kind of topical salves, heat, ice, red light therapy, and then autonomic nervous system regulation. So vagus nerve stimulation, there are lots of machines on the market. You can try This is just a little hack that I like to do. If you, the tragus, this part of the cartilage of your ear right here, if you put your thumb behind that and your forefinger very gently on the front, you can do a tragus massage, and that is great vagus nerve stimulation. And so if you feel some kind of autonomic dump coming on, that can be a really good strategy to help mitigate some of that. Okay, so a couple of things to touch on and how they present to me and my clinic. Tethered cord, we haven't talked a lot about yesterday or today. Every presentation of tethered cord that I have seen in my clinic has been occult, meaning that we don't see it on imaging. So that's a fun challenge to have to deal with. Many of the patients will not really respond to conservative management. And so if you've kind of tried everything and the patient is still having a lot of lower back pain, and that should say radiating, not radicular symptoms, symptoms going down into the legs, weakness, hyperreflexia, bladder changes in particular because of where the bladder is innervated, pain going up and down stairs, and sometimes incontinence with stairs. And lastly, any increase in neural tension. So if I see these symptoms collectively, then I have what's called a Wagner tethered cord screen. So I will get that out, go through that, and if that's positive enough, then I'm going to refer out to have someone else look at that who was much smarter than I am. Same thing, Dr. Henderson talked a lot about upper cervical instability for how that presents to me the majority of the time, bobblehead, brain fog, visual deficits or changes, hyperacusia, the cervical medullary symptoms that we've really been talking about most of the day today. And same thing, if I think that that is a possibility, I will get out a upper cervical instability screen and go through that with someone. And if that's positive, I will often recommend a cervical collar for a period of time to see what changes, if anything, and then that can be a pretty good indicator as well. POTS. Talked a little bit about that. These are the basic things that I think most of us know about. Hydration varies depending on who you talk to, how much. I've heard anywhere from 64 ounces to a gallon. Salt, also I would defer to you all for that, but I have heard anywhere from 3 to 12 grams. Compression I think is an interesting one. I think that it varies in terms of how people do with compression. Some people really like below the knee socks. Some people like thigh highs. Some people like leggings. It does not need to be super compressive. It can be 15 to 25 millimeters of mercury, just enough to give that little bit of integrity to get the blood back up to our heart and then therefore our brain. In my clinic, I really like to know, and this goes back to I want to know everything. What are your heart rate? What I do. Liquid milk of magnesia can be a fantastic little hack if you have skin sensitivities. It just gives a little bit of a barrier. I think everyone that I have tried that with, there's been 2 that it hasn't worked for, so I would give that a try if tape works well for you. So pacing, that's the other big thing, I think. Everybody has seen this Borg scale here. And there's kind of 2 recommended ways that you can work on pacing. Your heart rate, depending on what it does. And again, if there's pretty large vacillation in what your heart rate is doing, that can be a fairly reliable way of pacing. If not, then this is a little bit better way. And with regards to POTS, chronic fatigue, and some of what we're doing, depending on how deconditioned the person is or isn't, then we want to stay in these 3 to 4 area versus getting all the way up here. because we want to incrementally figure out where are you, we got to meet you where you are, and then that baseline should gradually improve. And again, depending on the amount of deconditioning, it's recommended that you increase about 10% per week. So it's pretty slow. Okay, so basically in summary, listen to what your body's telling you, move as often as you can and as much as you can to load the tissue. As Carley said, pain is multifactorial, and PT and OT are the cornerstones of some of that management. So that's all I got. Thank you.
Okay, we have time for a couple questions for Jodie or
My question is Jodie. Definitely a question that I've done. So for those folks that are helping us and those of us that are mental health for those of us that are in the mental health space, age-wise, and all we hear about is lift weights, lift heavy weights, cardio out. We have said we're up against the wall, if you will, of the grind our weights slowly. We get to a level where we just can't do more. And then you go into your doctor's offices who have nothing but great intentions of, well, you need to be lifting weights. And you're thinking, I just have setback after setback. So my question to you is, do you have good advice for how you can increase weights for those of us that are losing estrogen, that are losing bone mass, of how to keep up with that at a healthy pace?
Yes and no. It sounds like a cop-out, but it is really individualized. So what I would say to you specifically is, what are your mechanics when you're doing the things that you're doing? And so if it's a deadlift, if I don't engage here and I keep arched, that is going to feel terrible. And so it's really about the body mechanics and the proprioceptive piece of things and how you're doing what you're doing. Because again, I don't think there's any necessarily contraindication to lifting heavy weights. It's just how you do it. And that's where like a PT should come in, ideally, to perform a detailed movement assessment on what your compensatory patterns are as an individual.
one last question? Yeah.
Hi, I've actually seen Jodie. She's great. I'm a local mental health provider. I wanted to provide you an alternatives to Psychology Today. Psychology Today has actually really gone downhill in the last few years, been taken over by big tech companies. So pain reprocessing therapy directory is a really good one, as well as somatic experiencing directory and sensory motor psychotherapy. These are body-based trauma-informed therapies that really focus on the nervous system's role in mental health. So just wanted to share this with you.
That's great. Thank you.
Pain reprocessing therapy, somatic experiencing directory, and the sensory motor psychotherapy directory. I'm sure there's many more too, but those are the ones that I know of.
That's amazing. Thank you. I was actually looking to my mom and I see her taking notes. So good. Because part of the way I built this presentation was actually just walking around the rehab hospital and grabbing our dietitian and being like, do you have a resource for this? Do you have a resource for that? So thank you. I always love that.